Hi, our topic is brain plasticity and amputation. We chose this topic because we think that amputation is something we don't talk about enough in the biopsychological field. And after all, losing a limb is something that can happen to anyone. And of course, prosthetic were something found to be used as early as 900 BC. Surprisingly, we don't find we ha- rarely hear about the amputees. That's why this presentation will explore the impact of brain plasticity due to an amputation on people. Our three main subject is going to be one, the effect of amputation on the brain, two, neuroplasticity and prosthetic, and three, the phantom limb syndrome. But first, you need to know what is brain plasticity. Brain plasticity is the brain capacity to physiologically change and rewrite itself as a result of learning experience. Neuroplasticity is also responsible for repairing damage in the brain following injuries, example a stroke, or to adapt to damage done on the body. And our case is going to be amputation. The first subject is effect of amputation on the brain. After an amputation, there will be brain plasticity, but you have to know there's two types of it. The first one is the trigger brain plasticity. It is caused by a sensory motor deprivation. In other words, it means that the loss of the sensory input to the primary sensomotor cortex, also called S1, and the loss of the motor output from the primary motor cortex, also called M1. This plasticity is going to have multiple effects, but this main one is going to be that neuron from the imputated area of the brain are going to become responsive to its neighboring cortical. In other words, that would mean that it becomes sensitive and responsive to sensory input dedicated to another cortical that its own. The review was conducted by Estelle Ruffin, and to further understand her subject, she also paid attention to a study made in 1984 on monkey's brain. The study showed a reorganization of the sensory and motor map in the brain after an amputation. She used the same concept on humans. She tried to understand them. And to do so, she used non-invasive neuroimaging such as PET, MEG, and task-based fMRI. After getting her result, she was able to back up a model named maladaptive plasticity. It explained that level of expansion of the neighboring body parts corticals into intruded area is proportional to phantom pain. Is proportional to phantom pain. The second branch is use-dependent brain plasticity. It is the reorganization driven by compensatory use of intact limb on top of the deprivation of sensor. It is the activation of primary somatosensory cortex and the primary motor cortex due to a heavily use of intact limb. When an amputee loses a limb, they will tend to overuse the intact one. And this constant use of the remaining limb is going to be the cause of an activation in the um, in the cortical zone where they were linked to the lost limb. She also applied this concept to her study, where she saw that ipsilateral motor complex activation of 55% was present in the amputee group versus 80% in the control group. You may wonder what does ipsilateral definition is. It would be on the same side of the body as another structure or a given point. This data helped her also back up another model named the persistent representation. That would be that the firmer hand in the study, cortical representation, will still persist even after amputation. That will be another link to the phantom limb syndrome. Our second subject is brain plasticity and prosthetic. There's something named cognitive load, and it is present in you and me. But particularly in amputees, it would mean the accumulation of the mental resource needed to complete a task successfully and fully process the information of said task. It is something that's going to be way heavier to someone who lost a limb because of the brain plasticity and the neural pathway change. This is a concept derived from the cognitive load theory made by John Swaller in 1980. It is a concept that may highlight the fact that it is something that applies to everyone and that it will dictate every human activity. And again, it is something that can separate itself into main categories. The first one is going to be emotional fatigue, and the second one is going to be the neural fatigue.
Okay, so first I'm going to talk about brain plasticity related to ischemic nerve block. So this is basically a form of technique of amputation that promotes neuroplasticity by cutting off the affected limb circulation. So basically your brain is going to prepare itself because due to the degradation of the somatosensory cortex in the area of the affected limb, the brain prepares itself to get rid of the motor connections. However, it's like an anticipation. It doesn't get rid of it right away. It waits until the limb is either dead or removed. Um, the sensations of the amputated limb, upper limb, are transferred to the healthy contralateral limb as it takes over the region affected of the affected one in the somatosensory cortex. So, for example, if this hand is going through IMB, or it got removed, this hand is going to feel more. It's going to be more sensitive and basically like the input that would have gone to this hand is going to this hand now. I mean, it doesn't mean that if you touched a dead hand, I'm gonna feel in this one. I'm just saying, since the area of the brain was taken over, it's like your sensations are gonna be stronger on the other hand. So now, the change in activity in the brain. From the article or the review article that I chose from Wheaton, made in 2017, he says plasticity in sensory systems can influence motor control beyond motor cortex. So basically, what he means is that other parts of the brain make up for the loss of sensation. So let's say the example would be, oh, a blind person can hear more or smells more, has their other senses are more refined. So reduced sensation from the INB decreases the activity in the left somatosensory cortex and the cerebellum, which leads to an increase of activity in the parietal, occipital, and temporal lobes, which are responsible for the hand-eye coordination. So in his review, Neurorehabilitation in Upper Limb Amputation, Understanding How Neurophysiological Changes Can Affect Functional Rehabilitation, he talked about a study done a year prior, which he participated in. And it's basically about the reliability of visual and somatosensory feedback in skilled movement. He highlights in his review that the activation of the parietal lobes and occipital lobes and temporal lobe in patients performing tasks with one upper limb going through the IMB technique. So this is his study. The design was a group of participants were told to lift and place a block with their right hands, a little block with tweezers, though I forgot to write it in the PowerPoint, but with tweezers. And the action was done once with their senses intact, once with their vision impaired, and the other one with the limb going through IMB. So they collected this data with brain scans using functional magnetic resonance imaging, which is fMRI. We saw that in class. And basically, they came to the conclusion that the intact brain scan, this one, the one where there was no impairment of the view or IB or the sensation, it shows that the left somatosensory cortex were active the most because it was the right hand. During the impaired vision, which is the B, we can see that there's more red. So since they can't see, the somatosensory cortex was more active. It was more on feeling. Then the last one, the reduced sensation, which is this one, the posterior parietal and the occipital temporal areas were active to compensate for the lack of feeling. So for basically you're not feeling well, so you're not using the somatosensory cortex, so you're using more your sight and everything else. So it's to compensate, and it's the hand-eye coordination, as I said earlier. So now prosthetic and neuroplasticity. So after the acquisition of the prosthetic limb, the individual needs to relearn how to use it. So remake motor connections. So if you have a prosthetic limb now, you have to relearn how to walk and things like that. Chronic immobilization can lead to maladaptive plasticity, which is basically neuroplasticity gone wrong, as Riza said earlier. And this is why prosthetic devices with sensory feedback can help prevent that. Those are the fancy types of prosthetics. I don't mean like the prosthetics that don't move or anything. I mean the ones that have joints and like move. Like I don't know if you've seen those videos of like people with like fake hands and they like can actually use them like we use our hands. So, a study by Nambancha et al. In 2025 basically showed that amputees can have more difficulty with reasoning, information processing, attention, memory, language naming, etc., as it may alter the neural pathways affecting inhibition control. Before I go into the study, I just want to say like a few definitions so you're more you understand it more. The first one is event-related potentials. It's basically some patterns of the brain electrical activity measured by the EEG. We saw that imaging, like type of imaging in class too. But yeah, so it's like you can associate the activity of this certain type to a certain activity. So, and a role. So N2 is a distinct type of wave linked to inhibition and executive function, and P3 is distinct type of link to working memory of wave. I forgot the word wave. Linked to working memory, attention, and decision making. So basically they use two groups of 26 individuals with transtibial prosthesis and uh one group had that prosthetic, another didn't. It was like able-bodied people. And they tested them with in the resting state and with a go, no-go test. So basically they had to press a button every time they saw one of two images. No, one of four images. Two were go, two were no go. So two they had to press, two they didn't have to. With the collecting data, they basically did it with the EEG at the resting state, like I said, and to measure the brain activity during the go, no go activities, ERPs. The analyzing data, basically the results showed that the EEG results for the resting state were the same for both groups. However, the TTP patients' results for the ERPs were what's concerning. Their N2 amplitude increased in their response while their P3 decreased. And as they say in this article, P3 amplitude in TTP users group may indicate a diminished allocation of attention and cognitive resources towards inhibiting inappropriate or irrelevant actions in contrast to the able-bodied group. So basically, they're, as we said here, they have more difficulty with reasoning, information processing, etc. And lastly, with their N2 being low, the abnormal N2 levels show an issue with inhibition and executive function.
So I'm going to talk about the phantom limb, which is a common side effect of amputation. So basically, you may or may not know, phantom limb is the perception that a limb that has been amputated due to an injury or whatever reason is still present in the body and performing its normal functions. Following this amputation, there is an extensive reorganization in the brain, most prominently in the primary somatosensory and motor areas, because as we may know, the primary somatosensory cortical area receives and processes sensory information from the body to then send to the primary motor cortical area, which initiates movement and coordination. So this remapping, this rewiring of our brain causes an unbalance in the brain's functional organization, because what was the brain's organization before is not the same after amputation, because the brain tries to adapt to the loss of this limb. To talk more in depth about phantom limb, it's basically that a region that represented the missing limb in the primary somatosensory cortex, it becomes deprived of its primary input, which causes a shift in boundaries in the somatosensory body map. So basically, once neurons are deprived of their primary input, they become responsive to stimulations that activate the neighboring areas of that deprived area, which, like I said, this remapping causes adjacent areas of the limb to take over the cortical areas responsible for the missing limb, which leads to sensations in different areas. So we can take the example of hand and face. Basically, the hand area might be invaded by the face area, leading to sensations in the face being experienced as if they were the missing hand, which is a great example to explain what phantom limb is. So there was a study conducted by Brahmati and his group in 2019, which used tactile residual limb stimulations and 3T fMRI scanners. And if you guys don't know what 3T is, it's basically just the power, the force of the scanner, to explore functional connectivity changes in the sensory motor network of lower limb amputees that are experiencing phantom sensations. They use two tactile stimulations. One is the residual limb stimulation, and the second one is remaining foot stimulation. So basically, he had two groups, one experimental group, which contained 9 patients with unilateral lower limb amputations who were experiencing phantom limb sensation, and the other is the control group, which were consisted of 9 healthy and age and gender matched patients. So basically, each patient or participant went into the MRI scanner that measures brain activity and received gentle tactile stimulations on the residual limb and on the intact foot with a little soft brush. This study was basically to observe how the brain responds to the touch after limb loss. And basically, the study mostly focused on the primary motor and somatosensory cortices to analyze how strongly these areas were connected during the stimulation, and then eventually compared strengths of connection between the experimental group and the control group. They came to the conclusion that there was a decrease in interhemispheric connectivity. So basically, the communication between the same regions on the left and right side of the brain are weaker in the experimental group during both simulations, which reflect a disconnect across hemispheres after the imputation. But there was an increase in the intrahemispheric connectivity, which, to sum it up, that the brain areas on the same side of the brain, most importantly the opposite side of the amputation, are stronger connected in the experimental group, which reflects how our brain reorganized itself to compensate for the loss of the limb. So to conclude, amputation triggers significant changes in one's sensory motor network in the brain, which really just reflects how flexible and resilient this organ actually is. Our brain's plasticity reorganizes the connectivity of certain areas to adapt to the loss of this limb, which is pretty incredible. So, to summarize, we talked about the effects of amputation, which we can talk about how our brain has rewired itself to adapt. And the area that's largely affected is the somatosensory cortex. We also talked about prosthetics, which wearing a prosthetic means that we have to relearn motor skills, and even though they may improve the quality of life, they can bring some impairment too. And we talked about how brain plasticity after amputation can cause phantom limb sensation as the brain rewires itself. So to summarize, basically the brain plasticity is a great example to demonstrate how our behavior, our sensations, and sometimes our identity is tightly linked in the brain.